General physical examination. How do you want to score marks? Be thorough with general physical examination. That's how the final practical goes like. It's all about how well you present and how well you answer general physical examination. So I have summarized this general physical examination into two sheets. One, this sheet, which has pulse, respiratory rate, blood pressure, and JVP. And in the second sheet, as shown below, it has temperature, types of fever, physical examination, that is pallor, icterus cyanosis, clubbing, lymphadenopathy, and edema. So now let's go through it quickly. After you present chief complaints and history of presenting illness with several other important histories like past history, family history, drug history, and you summarize your opinion, we have to start with the examination, that is general physical examination. We start by saying patient is conscious, cooperative, well oriented, time place person. Then we take height, weight, we calculate BMI, and for BMI the normal value is 18.5 to 25. Anything more than 25 would be obese, and anything less than 18.5 would be underweight. So we move on to vitals. Pulse, the most frequently asked definition. What is pulse? Pulse is a pressure distension wave. LV, left ventricle contract against partially filled aorta. A wave is produced which is transmitted to periphery. It is felt on peripheral artery since the wave is being transmitted against bony prominence. So when you describe a pulse, you have to describe it as a rate, rhythm, volume, all pulses felt or not, character, radio radial, radio femoral delay, and the wall condition. And when you examine pulse, the three finger rule. This is most important question. That is, how do you examine pulse? Proximal finger compresses and stabilizes the artery on the bone. Middle finger feels the artery and counts the rate. Distal finger prevents the backflow. It obliterates retrograde pulse from the palmar arch. Then, what about pulse rate? Normal 60 to 100 per minute. Less than 60, bradycardia. More than 100, tachycardia. For bradycardia, the most important causes are physiologic, athlete sleep, pathologic, hypothyroid, hypothermia, hypoxia. Then we have tachycardia. Tachycardia is seen in anxious state, infancy, pregnancy. Then it's mainly seen in severe anemia, wherein your hemoglobin is less than 8 to 7 gram percentage. Then we see it in hyperthyroid, cirrhosis, nicotine, caffeine users. Liebermeister rule: for every degree rise in temperature, pulse rate increases by 10. Then pulse is described as regularly irregular, irregularly irregular. For regularly irregular, we have to know three minimum causes, that is atrial tachyarrhythmia, arrhythmia, AV block. For irregularly irregular, atrial fibrillation, atrial tachyarrhythmia plus AV block. We see peripheral pulses. We examine in uh, carotid pulse, temporal pulse, apical pulse, brachial pulse, radial pulse, femoral pulse, popliteal pulse, posttibial pulse, dorsalis pedis. Go through each of it thoroughly. Next, respiratory rate. Normal is 18 to 20 per minute. Less than 10 is bradypnea. More than 20 is tachypnea. For bradypnea, you can see bradypnea in increase intracranial pressure, hypothermia, hypothyroid. For more than 20 respiratory rate per minute is seen in anxiety, hyperthyroid, emphysema, pneumothorax. Respiratory muscles, the muscles which aid in respiration. For inspiration, main muscles involved is diaphragm, external intercostal. For expiration, it's a passive process. There's no main muscles involved. Accessory muscles of respiration. For inspiration, serratus anterior, sternocleidomastoid, pectoralis, and trapezius. For expiration, the accessory muscles involved are internal intercostal, abdominal muscles, latissimus dorsi. Then types of respiratory movement: abdominothoracic, thoraco-abdominal. In abdominothoracic, we place both the palms of the hand, one on the abdomen, one on the thoracic. Abdominal movement of the hand is more than the thoracic movement of the hand. It's just indicative of well-formed abdominal muscles, and it is predominantly seen in male. Thoraco-abdominal, thoracic movements is felt more than the abdominal. It's predominantly seen in female, and it just indicates well-formed intercostal, internal intercostal. Then abnormal breathing. As you can see, the main questions which will be asked, especially in a RS case, is Cheyne-Stokes breathing, Kussmaul's breathing, Biot's breathing. So what is Cheyne-Stokes breathing? Apnea, hyperapnea. There is increasing intensity of apnea, then it decreases, then there is a apnea period. It's mainly seen in left ventricular failure, increase intracranial pressure. Kussmaul's sign. Kussmaul's breathing. It's different from Kussmaul's sign. Kussmaul's breathing, there is tachypnea and hyperapnea. Tachypnea means increased respiratory rate. Hyperapnea means deep respiration. It's seen in diabetic ketoacidosis and rheumatic fever. Next, Biot's breathing. Biot's breathing is seen in meningitis. The main feature is rapid deep respiration plus pause in between. Then moving on to the next part, the favorite question again, the blood pressure. Since first year you have learned that the normal value of the blood pressure is average value is 120 SPP 80 dBP. The definition: lateral pressure by the moving blood column exerted on the wall of arteries. So blood pressure formula is cardiac output into peripheral resistance. So if the peripheral resistance increases, the blood pressure increases. If the cardiac output increases, the blood pressure increases. SPP. SPP is maximum blood pressure attainable in systole. DBP, diastolic blood pressure, minimum BP at the end of diastole. So when you look at hypertension, anything more than 140 bar 90, that is 140 SPP, 90 DBP, it's further classified into three grades: grade 1 142 160 SPP, 90 to 100 EBP. Grade 2, grade 3, as you can see, I have just added on 20 to each values in SPP and added 10 mm of Hg for DBP. And the blood pressure has other components like pulse pressure, wherein you subtract SPP and DBP from SPP. The normal value usually is 40 mm of Hg, and mean arterial pressure, that is DBP plus one third of pulse pressure. Its normal value is around 95 mm of Hg. Then ankle brachial index, it's the ratio of SPP in the ankle to the SPP at the brachial artery. SPP is measured by handheld Doppler. Um, JVP, jugular venous pressure. Even this is the most important question which you occasionally encounter in your postings. Be thorough with it. Just to summarize it or make it short, it's the undulant top of oscillating blood pressure in the right internal jugular vein, which represent volume and pressure changes in the right side of the heart. Basically, the um, right internal jugular vein is in line with the right atrium, so whatever changes happen in the atrium can be seen in the internal jugular vein. How do you measure JVP? So when you look at JVP measurement, the bed is inclined at 45 degree, and it's not the neck, it's the thorax which should be inclined at the 45 degree. One scale is kept at the upper level of JVP, the part which you can see through your eyes, the pulsating JV internal jugular vein. It should be parallel to the ground, and the second part is kept at the level of the sternal angle perpendicular to the first scale. So the distance is measured, and somewhere between 1 to 2 centimeter is usually how we see it. Then we add 5 centimeter because that's how the distance between right atrium and the sternal angle. So this is how you measure JVP. Jugular venous wave pattern, the JVP components and the waveforms. It basically has three ascending wave and two descending wave. A, C, V are the three ascending wave, and X and Y descent are two descending waves. So just know the basic physiology, how A wave is formed. A wave is formed by atrial contraction. V by venous filling of right atrium. C tricuspid wall closure. X X descent atrial relaxation. Y descent emptying of atria. As you can see, I have put letters in capital letter just to make it easy for you guys to remember. Then we have a large A wave, Canon A wave, giant V wave, and absent A wave. These are pathological condition, and you need to know at least two to three causes. In large A wave, we can see basically in tricuspid stenosis, here right atrial contracts generate A wave. When there is tricuspid stenosis, there is a difficulty for blood to exit from the right atrium, therefore the pressure increases. Large A wave is also seen in right heart failure, pulmonary hypertension. Canon A wave, there is a JVP spike which appears and it disappears. There is usually AV disassociation. In Canon A waves, we are usually finding it in heart block, ventricular tachycardia. Then absent A waves, in atrial fibrillation, there is no right atrium contracting. When there is no right atrial contraction, there is no A wave. It's just use of general knowledge. Then we have giant V wave. Tricuspid regurgitation is where we see giant V wave. So we have finished with the sheet one, and it's good that we got through it very quickly within 10 minutes. So you can go through it. If you want, again take a screenshot and read it just before the exams. Next we'll go on to the next part. Body temperature. And the usual thing patient comes to hospital with is that he has a rise in temperature and there's a fever association. That's the one of the important sign which patient notices and presents to you as symptom. Temperature, the core body temperature, is measured either under the tongue or rectum. Usually the routes of measuring includes oral. Under the tongue, the thermometer is kept for 3 minutes. Rectal temperature, zero point 0.5 degree more than oral temperature. The thermometer kept in the anal canal, 4 to 5 centimeter deep, for around 3 minutes, usually in infants. That's how we measure. Then axillary temperature, zero point 0.2 degrees Celsius less than oral. The shoulder is adducted and the thermometer is kept in the axilla. The normal temperature in degrees Celsius is 37 to 38, and in degree Fahrenheit is 98.6 to 100.4. At least know the normal value of temperature. Next, fever. What is fever? Fever, elevation of body temperature more than the normal. So when the examiners have to check your basics, that's the one of the question which the examiner tries. So be thorough with it. To make it very easy, I have approximated and round off the values. For degrees Celsius, just make sure you add 1 degree to every subsequent grade of fever. And for degree Fahrenheit, 2 degree Fahrenheit. For example, if normal is 37 to 38, mild fever will be 38 to 39. We have added 1 degree Celsius. Moderate 39 to 40, severe 40 to 41. Hyperpyrexia will be more than 41 degrees Celsius. Similarly, in Fahrenheit, 98 to 100, we add 2 degree Fahrenheit next, 100 to 102, 102 to 104, 104 to 106, and for hyperpyrexia it's more than 106. Then when you have went through all of this, make sure you just go through hypothermia once. Hypothermia is nothing but less than 36 degrees Celsius and less than 95 degrees Fahrenheit. Then we'll divide types of fever: acute fever, subacute, chronic. Acute fever, uh, because when you mention in your history of presenting illness, you usually use fever acute in onset or sudden in onset or chronic fever. So to be specifically clear, acute fever less than 7 days of duration of fever. So it's usually seen in malaria, viral upper respiratory tract infection. Subacute fever less than 2 weeks, seen in typhoid. Chronic or persistent fever more than 2 weeks, as you can think that only first disease which can come to your mind is HIV, TB, and cancer. Then we look at the night sweats. Usually we see in TB, brucella, subacute bacterial endocarditis, nocardia, lung abscess, and arteritis nodosa. Then hypothermia, anything which is less than 36 degrees Celsius or which is less than 95 degree Fahrenheit. The causes include hypopituitarism, hypothyroid, stroke, Parkinson, multiple sclerosis, cold immersion, cold infusion, pancreatitis, sepsis, prolonged cardiac arrest. Next, one of the favorite questions of examiners: fever types. No, so when we make it or convert it into graphical form, it will be easy to remember. So first, continuous fever, wherein there is a rise in temperature from the baseline, and at one point it fluctuates within 1 degree Celsius. So it doesn't touch the baseline and it fluctuates within 1 degree Celsius. That's the continuous type of fever. It's seen in lung abscess, lobar pneumonia. Next, remittent fever. Even this, here there is a rise of temperature, but at one point it fluctuates more than 1 degree Celsius. In continuous, it was less than 1 degree Celsius, but in remittent, it's more than 1 degree Celsius, and it doesn't touch the baseline. So the remittent fever is seen in septicemia, infective endocarditis, brucella, rickettsia. Next, intermittent fever. Here it touches the baseline in 24 hours. For example, malaria, tuberculosis, Kala Azar. Next, we have step ladder fever. Here, the fever keeps increasing in 2 to 3 days in step ladder fashion. There is increase and there is flattening of the wave. Then there is again increase, there is flattening. So it keeps increasing in 2 to 3 days. It's typically seen in typhoid. Then Pearl Epstein's fever. This pattern is similar to step ladder, but there is a febrile period in between step ladder fever for some 6 to 8 days. It's seen in Hodgkin's lymphoma. And the last part, the relapsing fever. Here, there is no fever for certain time, and then the fever again appears. There is relapse of fever. As you know, the classical malarial disease, Borrelia, rat bite fever, enteric fever, and lymphoma. And coming to the last part in the temperature examination, we look at fever periodicity, that is 12 hourly, 24 hourly, 48 hourly, 72 hourly. So if it comes 12 hourly and there is a gap of 12 hours, it's called double quotidian. It's seen in Kalazar. If it's 24 hourly, it's called quotidian. It's seen in falciform and vivax, Plasmodium falciparum and Plasmodium vivax. Then 48 hourly, it's called tertian fever. It is mainly seen in falciform, oval, and vivax of Plasmodium species. Then 72 hourly, we look at it in Plasmodium malaria, and it's called as quadrant fever. And with that, we complete temperature and fever part. Next, pain. Pain is the fifth vital sign. Pain usually it's the questions we ask is location, intensity, character, frequency, duration, and pattern. What are the types of pain? Somatic pain, it's well localized, comparatively well localized. Then we have visceral pain. It's deep, poorly localized. Then we have neuropathic pain. Then we assess the pain based on Wong-Baker's faces pain scale. Then faces pain rating scale. Then we have verbal pain scale. Then we have visual analog scale. So that's very simple part, the pain. Next, physical examination. In general physical examination, we look at pallor, icterus, cyanosis, clubbing, lymphadenopathy, generalized edema. So when you look at it, pallor, we'll have to know at least 2 to 3 causes for each of these and how to examine. So pallor is paleness of skin and mucous membrane. Sight, conjunctiva, tongue, oral mucosa, palmar crease, nail bed. Uh, in which conditions do we look? See pallor, anemia, shock, left heart failure, hypothyroidism, hypopituitarism, hypogonadism. Next, we have icterus. In icterus, uh, we see yellowish discoloration of skin and mucosa membrane. The sites which you look for is sclera, palm, sole, oral cavity. There's increased bilirubin, more than 2.5 mg per dl, and this is seen in jaundice, hypothyroid. Jaundice is the first answer which you should know when you say when they ask causes of icterus. Then again hypothyroidism, hypercarotinemia, phenol nitric acid exposure. Next, cyanosis. Cyanosis is the bluish coloration of skin and mucous membrane. Here there is increase in deoxyhemoglobin, that is the reduced form of hemoglobin, and there is even increase methemoglobin. The increase in deoxyhemoglobin is more than 5 gram percent. The causes of cyanosis, central causes include 5Ts and 2Es, that is tetralogy of Fallot. Then we have truncus arteriosus, then we have tricuspid atresia, then we have transport of great artery, then TAPVC. In 2Es, we have Epstein's and Eisenmenger syndrome, and for other causes includes asthma, COPD, carpal pneumonia, pleural effusion, high attitude, polycythemia. Then peripheral causes of cyanosis include decreased cardiac output, cold, frostbite, Raynaud phenomenon, vasoconstriction, artery venous obstruction. In mixed form of cyanosis, it is left ventricular failure. Then clubbing. Clubbing is the bulbous enlargement. There is increase in connective tissue and there is loss of onychonical angle. So when we look at the causes, we have respiratory causes such as bronchogenic carcinoma, bronchiectasis, empyema, lung abscess, asbestosis, cystic fibrosis. In CVS causes, we have infective endocarditis, cyanotic heart diseases, Eisenmenger. Then in GIT, we have inflammatory bowel disease, both Crohn's disease and ulcerative colitis. And the causes of unilateral clubbing are aneurysm and coarctation. Next, lymphadenopathy. There is involvement of more than two non-contagious lymph node groups. Lymphadenopathy is seen in TB, secondary syphilis, HIV. These are the common causes which you know. Then infectious mononucleosis, toxoplasma, histoplasma, CML, CLL, lymphoma. Then it's seen in SLE, systemic lupus erythematosus, rheumatoid arthritis, Sjögren, Kawasaki, sarcoidosis, amyloidosis, hyperthyroidism, NSAID, beta blocker, corticosteroid drugs used. And finally, the edema. Edema is nothing but the accumulation of fluid in interstitium. The types of edema are pitting with rapid recovery, less than 40 seconds, pitting with slow recovery, non-pitting facial edema. And the causes mentioned below: burns, kwashiorkor, nephrotic liver disease causes pitting, rapid recovery, pitting and slow recovery, hypertension, congestive heart failure, DVT. Then non-pitting hypothyroidism, filariasis, Graves, breast cancer, malignancy, and facial edema, classic nephrotic, hypothyroidism, and allergy.